And good morning, everyone. Thank you for joining us for this session on Waldenström Macroglobulinemia. Unfortunately, I'm not able to see your face today. I know that many of you we have probably already met in the past events, but for the newcomers, I hope we'll give you a good learning session here. So first, what is Waldenström Macroglobulinemia? So simply put, to diagnose a Waldenström Macroglobulinemia, there must be two criteria that's met. One is that there must be a particular lymphoma called lymphoplasmacytic lymphoma that's found in the bone marrow biopsy. And the second criteria is that there must be demonstration of monoclonal IgM protein in the blood. So as you're attending this Lymphoma Research Foundation event, you have heard probably there are many different types of lymphomas. So the lymphoplasmacytic lymphoma, which is a lymphoma version of Waldenström, is under the big umbrella of non-Hodgkin's lymphoma and is deriving from the B cells. So it's a B cell type of non-Hodgkin's lymphoma, and it also has a feature of an indolent lymphoma. So is a relatively rare form of indolent B-cell non-Hodgkin's lymphoma, just to put things in the big category. So what is monoclonal IgM? So IgM stands for immunoglobulin protein M. There are three major groups of immunoglobulins in our blood. So these are the immune proteins that our body produces to fight infections. The major groups are IgG, IgA, and IgM. So IgM is the biggest molecule among all immunoglobulins and is important for fighting various of infections. So in particular, in this lymphoma, it produces a monoclonal IgM that can accumulate in the blood that can be detected by special tests in the serum. So where does the name come from? First, macroglobulinemia really is speaking of the IgM protein being the largest immunoglobulin. So that's why it's called macroglobulinemia. And the name Waldenström really is attributing to the first physician who described this condition, Dr. Jan Waldenström, who published reports of several patients with a very specific clinical syndrome in 1944. As I mentioned, this is a rare form of low-grade or indolent B-cell lymphoma, only accounting for 1% of all non-Hodgkin's lymphomas. There are about 1,000 to 1,500 new cases diagnosed each year in the United States alone. The median age of Waldenström macroglobulinemia is 69, so most of our patients are in their 60s, 70s, or 80s, although we do occasionally have younger patients. It does have a higher incidence in Caucasians compared to other ethnic groups. Most of the Waldenström patient actually does not have a strong family history, so we believe just like most of the other cancers, this is a random sporadic event. But there's about 20% of patients who do have a strong family history, so we do believe that those patients do have a genetic predisposition for developing this type of disease. So what are some of the clinical features of Waldenström macroglobulinemia? So we know that this is a lymphoma that's primarily residing in the bone marrow. So bone marrow is a place where all your blood cells are being produced. So that includes the white blood cells, the red blood cells, and the platelets. So when the bone marrow is occupied by this lymphoma population, at some point, if there are too many of those lymphoma cells there, it's going to start to impact the production function of the bone marrow. In that case, we might start to see decrease in the good blood cell counts. For example, if we see reduction in the red blood cells, that will result in anemia. So when we see progressive anemia, we have to worry, is that due to actually the Waldenström overcrowding the bone marrow? Similarly, it can also result in reduction in the platelet counts. That's another sign of bone marrow function being impacted. Other things that can happen are mostly related to, actually the other thing, just like other lymphomas, is that Waldenström can also sometimes affect the lymphatic system, which includes lymph nodes. So it can cause enlarged lymph nodes or enlarged liver and spleen. Even though those manifestations are not as common in Waldenström compared to other lymphomas. So those are the lymphoma-related features of Waldenstrom. But there are many other manifestations that's related specifically to the IgM protein. So the first is called hyperviscosity syndrome. We're going to actually go into much more details of that. That's directly related to the high levels of IgM protein, resulting in the increased viscosity of the blood. And then the IgM protein can also cause various of other manifestations, which we're actually also going to go into each one in more details. That includes cold agglutinin anemia, macroglobulinemia, neuropathy, amyloidosis. And then very rarely on the left upper corner, you can see that there's a syndrome called Bing-Neill syndrome. So very rarely Waldenstrom as a lymphoma can involve the central nervous system, the brain or the spine or the spinal fluids. So when that occurs, it's called Bing-Neill syndrome, but it's extremely rare. So now let's go into those syndromes in details. So first IgM-related syndrome is hyperviscosity syndrome. So this can occur in about 15% of patients. It's directly caused by a very high level of IgM, resulting in the increased viscosity of the blood. And when the blood is flowing through the microcirculations, especially the small blood vessels, it can cause symptoms due to the slowdown of the circulation. So there could be many different presentations. The most common ones were headache, blurry vision, dizziness, or hearing impairment. Sometimes patient reports ringing of the ears. In the severe cases, it can cause confusion, stroke, heart attack. And some patients can also present with mucosal bleeding, like increased frequent nosebleed or bleeding in the GI tract. The IgM-related hyperviscosity syndrome usually only occurs when the IgM protein is above 3,000. I'm going to show you in the next slide how it's directly relating to the IgM level. And I do want to stress that patients who do present with symptomatic hyperviscosity syndrome, this represents a medical emergency. It requires urgent treatment, and most commonly urgent plasmapheresis. So here's a graph showing you that the predictor of hyperviscosity syndrome is directly relating to the level of IgM. So you can see that when the IgM level, here the label is slightly different scale compared to what you usually see. So for example, 30 would represent 3,000 milligram per deciliter. So when the IgM level is below 4,000, you can see that the rate of hyperviscosity syndrome is actually pretty rare. It's less than 5%. But as the IgM level increases, the rate of hyperviscosity syndrome really increases. So when IgM level is greater than 5,000 per milligram per deciliter, about 30% of patients might develop hyperviscosity syndrome. When it's greater than 6,000 per milligram per deciliter, then that percentage can increase to almost 70% of patients. So as we're watching patients, when the IgM level gets to a certain level, then we do start to worry about the risk of hyperviscosity syndrome. The other IgM-related syndromes are mostly related to IgM protein as an antibody that's becoming autoimmune antibody reacting with various proteins in the body. So one is called peripheral neuropathy. So when IgM protein is interacting with a nerve sheathing protein called myelin-associated glycoprotein or some other components of the nerve sheaths, that can cause small nerve damage and results in symptoms such as numbness and tingling, typically starting from the fingers and toes, and typically symmetrical. So the sensory peripheral neuropathy is the most common presentation for neuropathies. And if untreated, those neuropathy can actually progress, and at some point, even with treatment, they may not be reversible. So it's important to recognize peripheral neuropathy in Waldenstrom patients, and that is an indication for treatment. And I do want to point out that the IgM level does not need to be very high for a patient to have a peripheral neuropathy. Actually, very commonly, those patients who present with this have a fairly low IgM level. There are two syndromes that are related to IgM protein being temperature sensitive. So the first one is called cold agglutinin hemolytic anemia. In this case, the IgM protein under cold temperature would bind to the red blood cells, causing the red blood cells to aggregate and resulting in red blood cell destruction, leading to anemia. So that's called hemolytic anemia. So this occurs in about 5% of Waldenström patients. So especially during the winter time or upon cold exposure, patient might present with that type of picture. Another cold-associated IgM-specific syndrome is called cryoglobulinemia. So in this case, the protein will form a protein complex that depositing in various tissues, causing inflammation of the tissue. So that can cause vascular inflammation, resulting in a specific type of skin rash or sometimes joint pain, joint inflammation. And there's a phenomena that actually people may have heard about. It's called Raynaud's phenomena. When upon cold exposure, patient reports that their fingertips will turn pale or sometimes purple and painful. So that's because of the cryoglobulinemia is resulting in impaired circulation, so that's resulting in the very specific clinical syndrome. Occasionally, IgM light chain can result in a very specific type of deposition of fibrotic material to various organs. That's called amyloidosis. So amyloidosis can actually deposit in many different types of tissues, resulting in organ dysfunction, such as the heart, the kidneys, or the bowel, or the skin. There's a specific way of detecting amyloidosis by what's called Congo red staining, and the pathologist will be doing that on tissue biopsies or bone marrow biopsies. Sometimes we'll do a special fat pad aspiration biopsy. And then lastly, very rarely, IgM can cause deposition syndrome due to the heavy chain of IgM depositing in various tissues. So when we're suspecting Waldenström, the first thing is to go through diagnostics testing. So the most important one were the top two. One is the serum protein studies to demonstrate the monoclonal IgM protein and also to quantify the IgM protein. The second is a tissue biopsy to demonstrate the lymphoplasmacytic lymphoma. So most commonly would do a bone marrow biopsy because virtually all Waldenström is directly involving the bone marrow. Sometimes patient may present with lymph node enlargement, and the diagnosis could also have been done through the lymph node biopsy. And then once we do those tissue biopsies, then we'll do a number of different testing. For example, what's called immunophenotype to look at all of the protein surface markers expressed on those lymphoma cells. And based on those features, we can make a determination whether this is Waldenström lymphoplasmacytic lymphoma or some other lymphomas. Some molecular testing would be also important, which I'll touch on. In particular, what's called the MYD88 L265P mutation. So this is a particular mutation that's very common in Waldenström patients. It's actually present in over 90% of Waldenström patients. And we can often use the presence of this mutation to confirm the diagnosis of Waldenström's. Sometimes your doctor may do imaging studies to see, besides the bone marrow disease, whether or not you have any what's called extramedullary disease, meaning disease outside of the bone marrow. So those are typically, we're looking for lymphatic involvement, such as enlarged lymph nodes or enlarged spleen or liver. And then other blood tests are important to, for example, chemistry to look at your renal function, so kidney function and liver function. There are a number of other lymphomas that can resemble Waldenström. For example, another disease called marginal zone lymphoma, which is also a low-grade B-cell lymphoma that has a very similar surface marker expression. Sometimes the pathologist might be able to tell solely based on morphology, but sometimes they may have to rely on other tests such as the MYD88 mutation studies, because the MYD88 mutation is present in the vast majority of Waldenström patients and is only in a very minor group of marginal zone lymphoma patients. So if the mutation is present, that may help us to confirm the diagnosis of Waldenström. IgM myeloma is extremely rare. The presentation is more similar to myeloma, such as having lytic bone lesions, rather than more like a lymphoma presentation in Waldenström. And then lastly, not all lymphoplasmacytic lymphomas produce IgM protein. So small number of patients produce IgG protein, so those are not Waldenström, even though they have similar type of lymphoma. So I mentioned there are some important genomic mutations in Waldenström. The most important one is the activating mutation of MIDI88. So this mutation is present in 90 to 95% of Waldenström patients. Not only can that be used as a way to help to confirm the diagnosis, but it can also be a predictive marker. I'll show you in some later slides when we're talking about treatments, in particular the oral BTK inhibitor treatments. The presence of mediated mutation is correlating typically with much better response compared to those patients who do not have this mutation. Another important mutation in Waldenström patient is the CXCR4 mutation. So this is not as common, it's only present in about 30% of patients. The presence of this mutation usually is correlating with diseases of faster pace of progression and higher level of IgM protein. And there are also some data showing that the presence of this mutation might be correlating with not as optimal of a response to the BTK inhibitor compared to those patients who do not have this mutation. All right, so now let's focus on treatment of Waldenström's. The first question to ask is, does this patient require treatment? In fact, most of the Waldenström patients were diagnosed incidentally early on. That does not necessarily require treatment. For example, a patient may present with a very mild anemia, or their physician might have noticed they have some slightly abnormal protein, and then did further workup and led to the Waldenström diagnosis. The patient was feeling well. So for those patients, we typically can safely monitor without treatment. And then over a period of time, most patients do show progressive disease, and at some point, they will require treatment. So here are some of the standard treatment criteria. The first two are related to the bone marrow function being impacted by the lymphoplasmacytic lymphoma in the bone marrow. So if there are too many of those lymphoma cells occupying the bone marrow, the production function of bone marrow goes down, then you can start to see progressive anemia or progressive drop in other normal blood cell counts, such as the platelet counts. So when that's occurring and when you have a bone marrow biopsy showing that it's indeed those lymphoma cells that are causing those cytopenias, then that's indication for treatment. However, there could be many other reasons that's causing anemia or dropping platelet counts. So the first step is actually to rule out some of the other causes, simple causes such as iron deficiency anemia or some other nutrition deficiency or autoimmune disease that can cause anemia or lower platelet counts. So don't assume just because someone has a low blood counts is necessarily due to the lymphoma. Other things that is indicating treatment would be if patients having constitutional symptoms. So usually we say those are unexplained fever, chronic fever, significant night sweats, significant fatigue, loss of appetite, and significant weight loss. So those symptoms, if in the right clinical setting, meaning that if we're also seeing significant disease progression along with those symptoms, then we might think those are actually caused by the lymphoma. But those symptoms are actually not very specific, so none of those symptoms by itself is necessary indication for treatment unless we think that's actually related to the disease. If a patient is having a disease outside of the bone marrow, for example, enlarged lymph nodes or a spleen that are progressively getting worse, that's another indication for treatment. So those are typically similar to other lymphoma in terms of treatment indications. And then there are disease features that are solely related to the IgM protein. For example, if patient is having symptomatic hyperviscosity syndrome, as we discussed, or if their IgM level is going high enough to a level that we're starting to worry about their risk of developing hyperviscosity syndrome, then you do need to want to treat to prevent that from happening. Or if the patient is having symptomatic progressive peripheral neuropathy, or some of the other IgM-related complications, such as the cold agglutinin disease or macroglobulinemia, amyloidosis, and other autoimmune events. So when it's time to treat, then we have to think about the different phases of treatment. So I mentioned the word plasmapheresis. So this is a special treatment really only indicated for a patient who has very high IgM protein level and are having hyperviscosity syndrome, or we're concerned about the risk of developing hyperviscosity syndrome. So this is a procedure where we insert a large catheter into the vein, and the blood is flowing through a apheresis machine and then return to the patient's body. But during the process of flowing through the machine, the large IgM protein are extracted out. Doing this process will help to rapidly reduce the amount of IgM protein in the blood. So in the case of emergency, we do use that because this is a very rapid way within a matter of a session or two. We might be able to significantly reduce the IgM protein and prevent any severe complications caused by the hyperviscosity syndrome. But for patients who are not having very high IgM level and not concerned about the hyperviscosity syndrome, then the plasmapheresis is not indicated. The more relevant treatments are what we call cytoreduction therapy because we want to treat the underlying lymphoma. So the purpose of the treatment is to reduce the underlying lymphoma burden and also as a result to reduce the IgM protein production. And then we'll touch on the maintenance therapy after that. So before we go into, we're going to talk about various clinical trials to assess how effective our treatment regimen is. So we do need to mention a few standard terminology for you to understand the results. So how do we evaluate the response for Waldenström treatment? Based on how good the response is, there are a few categories. We look at the response by how much the IgM protein has reduced compared to the pre-treatment baseline. We can also look at how much disease has been reduced from the bone marrow initial involvement, or if patient has baseline enlarged lymph nodes or enlarged spleen, how much that has reduced after the treatment. So the best response is complete response. So in that case, after a course of treatment, there's no longer any detectable monoclonal IgM protein. And also, when you do a bone marrow biopsy after treatment, there's no residual lymphoma left in the bone marrow. And if you do a CT scan, there's no abnormal lymph nodes or abnormal spleen. So if all of those criteria are met, it's called complete response. I have to say that in Waldenström, complete response is extremely hard to achieve. So most of the time, we actually are very happy to see partial response or very good partial response. So partial response refers to reduction of the IgM protein from baseline by at least 50%, and also reduction of the enlarged lymph nodes or enlarged spleen. So if that's achieved, it's called partial response. But if patient has a very good reduction, greater than 90% reduction of the baseline IgM protein, that's called a very good partial response. So I think in Waldenström, this is a very high standard to achieve, and very good partial response is a very deep response. So there are also something called minor response. So basically, there is definitely reduction of IgM protein, but it didn't meet the 50%. It's between 25 to 49%. And then the stable disease are basically not too much change, not significant change compared to baseline. So if it's between 25% reduction or 25% increase, that's called stable disease. And then lastly, progressive disease are referring to those patients who, after treatment, actually had worsening of their disease with greater than 25% increase in the IgM protein or other signs of disease progression. So you might hear the term overall response. So this is referring to patients who are achieving at least a minor response. So at least 25% reduction of the IgM protein. A major response rate refers to patients who achieve at least percent of patients who achieve at least a partial response, so at least a 50% reduction of the amount of disease. And now to measure how long the duration of response lasts, we use the term progression-free survival, and sometimes we use the term duration of response. So there's minor differences, but very similar concept. Okay, so now let's look into the treatments that are available. So there are several categories of treatments that are available. We have conventional treatments, which include chemotherapy. There are two classes of chemotherapies. One is called alkylating agents. So primarily the two agents that are most commonly used, one is called bendamustine. The other is called cyclophosphamide or Cytoxan. Another category of chemotherapy is called pure analogs. So the one that's most commonly used is fludarabine. So between these two classes of chemotherapies, the alkylating agents are much more commonly used because there's less long-term toxicity compared to the pure analogs. And then the next big category is called the immunotherapy with monoclonal antibodies. So we're going to talk about Rituximab or Rituxan. So many patients who have been through treatment might have seen this agent. And then another similar monoclonal antibody is called ofatumumab. And then there's another category of treatment which is called proteasome inhibitor. So the one that's most commonly, most well studied is the Bortezomib or Velcade. But there are some newer proteasome inhibitors in this class. And then lastly, the IMiDs, thalidomide, lenalidomide, they're very commonly used in myeloma, another disease that have some similarity to Waldenström, but they're not very commonly used in Waldenström because the initial studies show some unexpected side effects. But the more exciting one for new treatments for Waldenström are oral targeted therapies. So currently, the ones that are FDA approved are the two drugs under the category of BTK inhibitors. So we'll go into more detail about what does it mean to be BTK inhibitor. So that includes Ibrutinib, Imbruvica, or Zanubrutinib, Brukinsa. There are also two other BTK inhibitors I will touch on when I talk about clinical trial data because they're also very promising new agents. And then lastly, there's a different class of oral targeted therapy called BCL2 inhibitor, represented by venetoclax. So first I want to start with immunotherapy. So immunotherapy here is referring to monoclonal antibodies specifically targeting a molecule called CD20. And the two drugs that are listed here I already mentioned. So CD20 are surface molecules that are expressed on the lymphoma cells. So those are represented by the yellow triangles on the surface of the lymphoma cells. And the Y-shaped protein are the antibodies. So the antibodies are able to specifically recognize those molecules on the lymphoma cells and therefore label all of those abnormal lymphoma cells. And when they're labeled, the immune system would then come in to help to destroy those lymphoma cells. So they're, for example, natural killer cells or macrophages or T cells that are activated, and also complements that are activated. So the synergy of all of those different immune system components will help to kill the lymphoma cells. So that's how monoclonal antibody immunotherapy works. Rituximab has been studied as a single agent in the treatment of Waldenström's, and it can give a response, overall response rate anywhere ranging from 35 to 60%. So it's somewhat effective, but by itself is not as effective as in combination. So in fact, most commonly, Rituximab is used in combination with chemotherapies, such as in combination with bendamustine or cyclophosphamide plus steroids, or with pure analogs, or with the proteasome inhibitor Bortezomib plus steroids. So when it's used in combination, the overall response rate is very high, it's 80 to 90%. There's one very unique phenomena associated with Rituximab use. It's called IgM flare. So typically when we're treating a Waldenström patients, if the treatment is effective, then we would like to see the IgM level improve with the treatment. However, if rituximab is included in the treatment, then instead of seeing the drop in the IgM level right away, we might initially see an increase in the IgM level. So that increase is not really a sign of failure of treatment, but rather is just a cytokine-mediated phenomena, and it's a transient phenomena. So that's called IgM flare. IgM flare is fairly common among when rituximab is used as a single agent. So 60% of patients might see IgM flare. However, when you combine rituximab with chemotherapy, that really significantly reduces the incidence. For example, in the Bortezomib, rituximab, dexamethasone combination, the flare is only seen in 9% of patients. When it's combined with bendamustine, it's also in the 10 or 20% range. So much lower incidence of IgM flare when it's combined with chemo. So cyclophosphamide-based regimens were the earliest studied regimens. There has been many studies, many cyclophosphamide-containing chemotherapies that are commonly used in all different B-cell lymphomas. For example, R-CHOP or RCBP used to be the very commonly used regimens for indolent B-cell lymphomas. And then for Waldenström, we have got rid of some of those agents within those combinations. So using the minimum bare bone of only cyclophosphamide, one chemotherapy drug plus rituximab immunotherapy drug plus prednisone, a steroid. So only one chemo versus 2 or 3 different chemotherapies in the different regimens. The reason why we're favoring the simpler regimen is because for Waldenström, the response rate is actually not too different if you're reducing those other agents, and it does really help to reduce the side effects. So in particular, the neuropathy and also the infection risk is much, much lower when you're getting rid of some of those other chemo agents. So that's why cyclophosphamide plus rituximab plus steroids is becoming the standard when this agent is being used for Waldenström. So nowadays, the most commonly used combination is cyclophosphamide chemo plus rituximab immunotherapy plus dexamethasone, a steroid. So this particular combination reported by the Greek group in the very large phase 2 study showed 80 to 90% response rate with a median progression-free survival of 35 months, almost 3 years, and the median time to next treatment of 51 months. And it's generally a well-tolerated regimen. They have not, in the short-term follow-up, did not observe any secondary bone marrow disease, such as myelodysplastic syndrome, MDS, or secondary acute leukemia. So well-tolerated regimen, usually we use that for older patients when chemotherapy combination is being considered. Another chemotherapy which is actually gaining more favor in the recent years is called bendamustine rituximab combination. As I mentioned, bendamustine is a alkylating agent chemotherapy, and rituximab is an immunotherapy. So this particular immunochemotherapy combination had been studied in a large randomized phase 3 clinical trial. Actually, this trial included many different types of indolent lymphomas, but there are some Waldenström patients included as well. So patients were randomized between BR, bendamustine rituximab, versus R-CHOP, which is one of the other commonly used cytoxin-based regimen. So you can see that the response rate are both very high in both arms, so about 95% for either treatment arms. Very effective treatments. However, if you look at the side effect profile, the rituximab bendamustine combination seem to give much less of low white blood cell count called leukocytopenia. There's much less infection complications. There's also much less of neuropathy. And if you look at the long-term outcome, so this is the progression-free survival among the 41 Waldenström patients included in that large study, you can see that the red line represents the BR combination, gives you a much longer progression-free survival compared to the R-CHOP, which means that you can have a much longer disease control. The median progression-free survival for BR is 69.5 months compared to only 28 months for the R-CHOP. So it's a better tolerated regimen and it's give you a similarly very high response rate and much longer duration of response. So that's why BR has become the more favored frontline treatment immunochemotherapy combination, in particular for patients who are fit or younger patients who we think they can tolerate that relatively well. Even for older patients, we can often use this regimen with a reduced dose of the chemotherapy. Another combination that's quite commonly used is the use of a proteasome inhibitor. So the one that's best studied is the Bortezomib or Velcade-based regimen. So in particular, when that's combined with dexamethasone, a steroid, and the Rituximab immunotherapy, it does result in reported overall response rate of 96%, so quite a high response rate. Major response rate of 83%. So these are greater than 50% reduction, at least 50% reduction. But the main problem with this regimen is the neuropathy, because bortezomib does have a risk of inducing treatment-related peripheral neuropathy. And since Waldenström patients are more prone to having neuropathy, the rate of neuropathy is actually quite high with this regimen. So there has been some modifications of this regimen, using, instead of twice-a-week dosing of bortezomib, using once-a-week dosing, and also to use a lower dose. And nowadays, we often also use subcutaneous injection versus IV administration. So those measures can help to reduce the rate of peripheral neuropathy. But it's still a problem. So you can see that even with the modified regimen, the peripheral neuropathy is still present in 46% of patients. Even though most of those are relatively mild, the severe neuropathy is only in 7% of patients. There are some newer proteasome inhibitors, such as carfilzomib, which has lower rate of, actually it doesn't really have any significant risk for peripheral neuropathy, so that would be another good alternative treatment. And then exazomab is another novel proteasome inhibitor. So those are the what's called immunochemotherapy combination that's helped to settle reduce. So with those treatments, hopefully we can reduce the amount of lymphoma cells in the bone marrow and therefore having significant reduction of the IgM protein level. Once we achieve a response, then the next question is, do we need something to maintain this response to have a longer control of the disease? So here is the concept of maintenance Rituximab. So there has been a very common practice to use Rituximab, the immunotherapy alone, given once every 2 to 3 months for a 2-year period of time as a way of maintaining the response. So that's called maintenance Rituximab treatment. So the use of this was supported by several retrospective analyses of Waldenström patients, looking at patients who were treated with various of Rituximab-containing combinations initially, and then once they achieved a response, there were some patients who did receive Rituximab as a maintenance therapy for 2 years versus those patients who did not receive maintenance therapy. So again, retrospective study. So in this report from Dana-Farber of almost 250 Waldenström patients, you can see that the Rituximab maintenance, which is the solid line, compared to those who did not receive maintenance, which is the dotted line, did result in a significantly prolonged progression-free survival and even overall survival for those patients. So based on this, there has been a lot of patients who are offered maintenance Rituximab treatment. However, interestingly, there's a newer study that was reported in 2019 at the American Society of Hematology meeting. It's a large study from Germany where they had over 200 Waldenström patients randomized. So all of those patients initially received bendamustine Rituximab induction therapy for 6 cycles. And then after that, those patients were randomized between receiving Rituximab maintenance versus observation. And their result showed that the patient who received rituximab maintenance had a progression-free survival of 100 months, median progression-free survival 100 months versus 83 months for those who were in observation. However, it did not meet a statistical significance in terms of the difference. So the conclusion at the presentation at the meeting was that there doesn't appear to be a significant benefit of rituximab maintenance. So that's making the rituximab maintenance a little controversial issue. So we're waiting for long-term follow-up from that study. It hasn't been officially published yet. So those were the conventional treatment with immunotherapy, chemotherapy, or the combination of those. In the recent years, a newer form of treatment has emerged as a very popular treatment. So this is called oral targeted therapies. The first one that's available is Ibrutinib. So Ibrutinib is the first generation BTK inhibitor. It was initially FDA approved in 2015 based on a small study from Dana-Farber in Waldenström patients. And then in 2018, FDA has granted additional approval based on a larger phase 3 study, so in combination with Rituximab. So this can be used either by itself as a single agent or in combination with Rituximab. So what is BTK? So BTK, the target of Ibrutinib, is an enzyme that's sitting inside the tumor cells and is a very important player in the B-cell receptor signaling pathway. So Waldenström lymphoma cells are B cells, and they're relying on some feeding signals from the microenvironment they're living in for survival and proliferation. And those signals are transmitted by this B-cell receptor sitting on the surface of the cells. And once they bind to the receptor, it's going to send a signal into this nucleus through multiple enzymes along the pathway. So this is called the signaling transduction pathway. And BTK plays a critical role in the B-cell receptor signaling transduction pathway. It is also playing an important role in the cytokine receptor pathway as well. So by blocking the BTK using agents such as Ibrutinib or Zanubrutinib, which work the same way, you can block the crosstalk between the tumor cells and the supportive environment they live in. So that can lead to the tumor cells to go through cell death and reduce their proliferation and reduce the production of the IgM protein. So Ibrutinib single agent was initially studied in relapsed refractory Waldenström patients, reported by Dr. Trian in 2015. So in the 63 patients that were treated, they reported a very high overall response rate of 91%. Remember, this is an oral medication. So this is oral medication patients take continuously for as long as it's working and as long as they're tolerating. So it's an oral continuous chronic treatment. So with the oral agent, a very high response rate. The major response rate is 73%, and the 2-year progression-free survival was 69%. And then the results was later confirmed by a larger international study in the rituximab refractory Waldenström patients, again reported a very high overall response rate and major response rate. So this is the randomized phase 3 study looking at Waldenström patient who has either previously untreated or treated, so basically frontline as a frontline or subsequent line of therapy. So patients were randomized 1-to-1 to receive either Rituximab plus placebo, so basically Rituximab alone, or Rituximab plus Ibrutinib. This is actually probably the first phase 3 randomized study in Waldenström because it's a relatively rare disease. It's difficult to run very large trials. So this is actually a collaboration, international collaboration among many institutions. So this study showed that by adding Ibrutinib to Rituximab, you significantly increased the response rate. You can see the bar graph on top. So overall response rate was over 90% for the combination versus less than 50% in Rituximab alone. If you look at the level of IgM reduction, the patient who received ibrutinib combination in the green line has a much more significant IgM reduction compared to those patients who received rituximab alone. So based on this study, FDA granted the combination as an additional approval for Waldenström Macroglobulinemia treatment. And you can see that the progression-free survival curve is looking much improved by adding ibrutinib to rituximab in the green line compared to rituximab alone. So from the studies using ibrutinib, we have learned something about the importance of the genetic mutations in Waldenström in terms of correlating with response of treatment. So as I previously mentioned, there are two important mutations in Waldenström patients. The first one is the MYD88L265P mutation. This was found in the vast majority of Waldenström patients. So the patient who actually do not have this mutation is very relatively rare, less than 10%. And then the CXCR4 mutation is present in about 30% of Waldenström patients. So in the studies I mentioned previously using ibrutinib, it has been observed that the response rate were impacted by the presence of either or both of these mutations. So here's a summary. You can see that we're dividing by all patients being treated with the ibrutinib or patient who has the MYD88 mutation only, so a single mutation, and they don't have the CXCR4 mutation. So those are, WT stands for wild type, meaning normal, no mutation, okay? So the second column is single MYD88 mutation. The third column are patients who has both mutations. And then the last column is the fourth column is for patients who do not have MYD88 mutation. So remember, those are the minority of Waldenström patients. It's only about 5 to 10% of patients. So looking at the response rate, the overall response rate appears to be the highest for patients who only have MYD88 mutation, and still pretty good for those double mutants, and 60% only for those who do not have MYD88 mutation. If you look at the major response, it's following the same trend, and very remarkably, patients who do have MYD88 mutation only have nearly 100% major response. And then even for those patients who had double mutation, they can still have decent, about 2/3 of the patient had a major response. But those patients who do not have MYD88 mutation, 0% of major response. So all of the 60% response were minor response, so it's not a very good type of response. Very good partial response, again, is following a similar pattern. So basically the trend is that if patient has a single mutation only in MYD88, then they seem to have the highest overall response and the deepest response. If they don't have MYD88 mutation, they have the lowest response. If they have double mutation, then the response is not as good as those single mutation, but they're still fairly decent. The main difference is that those patients with double mutation appears to take longer to get to their major response, so 6 months versus 2 months. Okay, so long-term follow-up is confirming that those patients with single mutation seem to do better than double mutation compared to those who do not have any mutations. I won't go into too much details for the sake of time, but just to summarize, ibrutinib is basically FDA approved as a single agent or in combination with the anti-CD20 monoclonal antibody. Again, this is oral therapy, daily, once daily, oral therapy, continue until progression. It does have very high response rate. The main side effects of ibrutinib, which is something that we do need to stress among all BTK inhibitors, are maybe some mild GI side effects, but the more concerning ones were some bleeding risk, hypertension, cardiac risk, primarily cardiac arrhythmia, in particular atrial fibrillation. And then it can also cause some low blood counts, rarely skin rash, and some patients may experience some muscle and joint pain. But the cardiovascular risk is the main thing that we really monitor very close for. The second generation BTK inhibitor, zanubrutinib or Brukinsa, is designed to be a more selective inhibitor for BTK. So ibrutinib, the first generation, inhibits not only BTK but also some other enzymes which might account for some of those side effects profiles. So by having a more selective BTK inhibitor, we're hoping to see a better toxicity profile. So this is FDA approved in August of 2021. So there's a large randomized phase 3 study directly comparing head-to-head of zanubrutinib versus ibrutinib in patients with MYD88 mutated Waldenström patients. And you can see that both are giving you very good response. So the response rates are very similar. There may be numerically more of a very good partial response, deeper, but it wasn't statistically significant. The progression-free survival seemed to be also very similar. So they're both very effective treatments. And then again, we're seeing the impact of the CXCR4 on the quality of the response. So the presence of the CXCR4 mutation does reduce the level of a deep response. So this is the long-term safety analysis. This is what we are really mostly interested in because we're hoping that the more selective inhibitors might have a better safety profile. So it's quite significant to see that the rate of atrial fibrillation, which is the cardiac arrhythmia, really significantly reduced from 15% to 2% for patients who were treated on this study. There seem to be some minor improvement in other side effects such as diarrhea, but I think the most significant finding is the reduced cardiovascular risk. Acalabrutinib is another second-generation BTK inhibitor similar to zanubrutinib. It's not yet FDA approved, but it has been studied in this phase 2 study in Waldenström patients. Again, it's reporting a very high response rate. So overall response rate 93%, and major response rate of 80%, so quite encouraging. So this is another agent to look out for. Again, very impressive progression-free survival curve. Future directions, I do want to touch on some very exciting new treatment options. So the zanubrutinib and acalabrutinib is what we call second-generation BTK inhibitor, but there are also third-generation BTK inhibitors, such as LOXO305 or ARQ531. These are the inhibitors that are designed to try to overcome resistance to the earlier BTK inhibitors, because the earlier BTK inhibitors are what we call irreversible binding or covalent inhibitors. They rely on binding to one particular amino acid residue. Sometimes the disease might develop mutation in that particular residue and disease might become resistant to those BTK inhibitors. So it's very promising to see that the third generation BTK inhibitors actually is able to help to overcome those resistance. And then the BCL2 inhibitor, venetoclax, I'll touch that on very briefly, and then I'll also touch on some the CAR T. There are a lot of, you can see there are a lot of novel agents that are being studied in Waldenstrom's. So BTK resistance, it can occur in patients who are being treated with the earlier BTK inhibitors, and most of those are related to the BTK mutations in those molecules, and some other patient may have PLC gamma-2 mutation. So the LOXO305 or portobrutinib, the third generation BTK inhibitor, has been studied in various B-cell lymphomas. If you focus on the Waldenström in the red box, you can see the vast majority of the patients actually responded very beautifully, even for those patients who actually were resistant to prior BTK inhibitors. So very promising. And then venetoclax is another oral agent that targets the cell death machinery. It's a very different mechanism of action. And in this small study in previously treated Waldenström patient, it also reported a very high response rate, 80 to 95%. So another very promising agent. This is not yet FDA approved, but is actively being studied in Waldenstrom's. You might have heard about CAR T, which is a chimeric antigen receptor T-cell therapy. So it's a cellular immunotherapy. You'll probably hear some sessions focusing on the CAR T therapy, so I won't go into much details, but just want to mention there are some CAR T studies that are including Waldenström patient as well. Many ongoing clinical trials in Waldenström Macroglobulinemia. We do have a number of those trials open at Northwestern. If you're interested, you can contact us. And lastly, the NCCN guidelines for Waldenström treatment. The preferred regimens include bendamustine rituximab, bortezomib, dexamethasone rituximab. Those are the two conventional treatments, or the two BTK inhibitors, ibrutinib or zanubrutinib. And then there are a number of other recommended regimens as well. So many different treatment options for Waldenström and many new agents being developed for Waldenström. I really think we're at a very good time and being very optimistic about the future of Waldenström patients.